Let me invite Lekha for the last talk in this session. Lekha is consultant in medical retina at Giridhara Institute, Kochi. Dr. Lekha will talk to us on anti-VEGF in wet AMD, simplifying treatment paradigms based on evidence.
Good afternoon. I thank Dr. Giridhar sir, who unfortunately cannot join us today, Dr. Thomas Cherian, and Scientific Committee of KSOS for giving me this opportunity. But before I start, I want to pay respects to my beloved chief, Dr. S.S. Badrinath. So age-related macular degeneration, or AMD, is an important cause of blindness in elderly population, and it affects about 3.1% of the population in India. The hallmark of neovascular AMD is choroidal neovascular membrane. The visual loss due to CNVM not only affects the lifestyle and the independence of a patient, but the treatment of AMD itself causes significant economic impact on the nation. And the discovery of vascular endothelial growth factor, which we call it as VEGF, was an important milestone in our understanding about AMD, and the subsequent development of the anti-VEGF drug have really changed the way that we manage the disease. Followed this was a series of randomized controlled trials which proved the efficacy of these anti-VEGF drugs. But unfortunately, the superior outcome which was demonstrated in the RCTs could not be translated into real-world evidence. So we will look into this in more detail. These are the various anti-VEGF drugs that we have at our disposal, starting from bevacizumab, ranibizumab, aflibercept, and the latest one being brolucizumab. And there are these are some of the major trials that has been conducted on these different drugs, utilizing different regimens on different populations, and all these mostly demonstrated good structural and functional outcome. It definitely helped to reduce the rate of visual impairment due to AMD, but these results were not seen in real life over a long time. So let's go into a little more detail. The first regimen that was tried was a monthly regimen, which was used in the major trials Anchor and Marina. And this is which proved the efficacy of ranibizumab as a treatment for neovascular AMD. And this set the bar for the newer therapeutic approaches, because the use of this drug not only helped to stabilize the visual acuity, but actually caused a gain in a significant number of patients. And for the first time, we were experiencing a gain compared to what was happening in the laser and the PDT era. But the main problem here was a significant burden due to the necessity for monthly injections. So this changed the trend towards PRN or prorata, where the patient continued to visit every month, but the injection is decided only based on the activity of the lesion. But this unfortunately could not maintain the visual gains over long term. And moreover, even though the injection was not given, the patient still required monthly visits. So the next attempt was to make it into bi-monthly dosing, and fortunately at this time aflibercept with a higher efficacy and a longer duration was available, and it was found that bi-monthly is almost as effective as monthly racimab, and we can see it could really reduce the number of injections that was needed. But still, this also was a significant treatment burden. It was only just once in month to once in 2 months. So we wanted little more individualized treatment regimens, and that led to the treat and extend strategy, where after the 3 initial monthly loading doses, you slowly start extending the interval of the visits by 2 weeks, but at every visit, irrespective of the situation, an injection is given. And at any time, if you see that, and if the disease remains stable, you can keep on extending the interval to a maximum of 12 to 16 weeks. But any time, if you see that the disease is active, you reduce the interval. So here it is more of a customized treatment. You try to give the optimum benefit of the anti-VEGF, but at the same time try to reduce the treatment burden. And it is found that this is now the regimen that is preferred mostly by the clinicians in US. So this is just to explain the same thing. Any activity, you give the loading dose, then keep them following up, and during follow-up, any evidence of reactivation, either in the form of a new intraretinal fluid or subretinal fluid, you have to reduce the interval. And when do you stop? When you see that already fibrosis has occurred, there is no more exudation, and if the patient is stable at 2 to 3 visits at subsequent intervals, you can either totally stop or then switch on to a PRN basis. And you should also be vigilant about the fellow eye in these patients. And we have a lot of literature evidence to support now that the T&D regimen works as good as a monthly regimen or the PRN, as good as a PRN regimen or the monthly regimen. And we can see that over the 12 months with 5.4 injections and 8.3 visits, we had a gain of 5 letters comparing to the 12 injections and the 12 visits that was required in the Marina Anchor trials. So what's happening in the real world is fewer injections, fewer visits, but little fewer visual gain. But still, these patients are protected from severe visual loss. So now we have little more options available, and the next new drug that has come is brolucizumab, which is the main advantage is because of smaller molecular size, we have more drug per dose, so there is more affinity, more penetration, and also significant longer duration of action. And the Hawk and Harrier studies have proved that brolucizumab given once in 12 to 16 weeks can be as good as a monthly racemab. And moreover, these newer drugs caused much more drying of the retina, and they could maintain it for a longer period. It was especially useful in the treatment-resistant cases. But a little catch here is the risk of inflammation that was associated with the use of this drug, but that has been again controlled. And now we have a lot of data. This is like one of the largest meta-analysis comparing all the 4 drugs that was available, and that has shown that it is a proactive treatment regimen, that is a treat and extend, that is gives better outcome than the reactive, where you wait for a reaction to happen and then decide about the injection. And another factor which is important is the frequency of injections in the long term. So maybe we can follow a treat and extend regimen, but once come to the choice of the drug, all the drugs are more or less effective. But to start with, we can maybe start with ranibizumab or even bevacizumab or aflibercept. Aflibercept is especially useful when after the loading dose, if the fluid is still persisting, and in those recalcitrant cases, the other option we have now is a brolucizumab. So when do you change the drug is when you see that the fluid is persisting even after the first 4 aggressive treatment, or when you want to increase the interval, you can go for these newer drugs. But we should always remember that we need not dry up the retina totally as seen in the fluid study. We should also be aware of the conditions which can cause inadequate response, and what is now generally followed is after 3 to 6 injection, if your particular drug is not working, you can change it. And we have evidence here also where switching to aflibercept or even to brolucizumab has given results. But actually, if you see, it is the anatomical improvement that is more important than the functional improvement. And the latest arrival, which is going to hit our market soon, is a faricimab, which is a bispecific immunoglobulin monoclonal antibody, which is effective not only against VEGF, but also against angiopoietin 2. So it is supposed to give better vascular stability. And this also has been proved in the RCTs by name Tenaya and Lucerne. And this is found to has the potential to extend the interval with sustained efficacy. Here the interval has been stretched to up to 16 weeks, that is as good as 4 months. Another newer drug that we are going to have very soon is aflibercept high dose, that is 8 mg, which is also found to be superior to what we are available now. While these new drugs are emerging, we should also try to see what is the reason for this gap between the RCT and the real world evidence. And these are some of the important reasons that was found in this study. Not only it's a financial burden, but also the burden of visits, those who are dissatisfied with the treatment, and even the distance factors. So what's happening is once a patient has perceived lack of efficacy with the treatment, that will lead on to poor compliance, which in turn lead on to further decrease in visual acuity. And it is this visual cycle that we have to break. So we also need to have a change in our mindset that contributes to the under-treatment. And forever we keep talking about the economic burden to the injections, but let us look into the other side of the coin. What is the economic value of this therapy? So this is the question, what economic value do this treatment generate for the patients and also to the society? And it was found that the increased equity with anti-VEGF definitely provides economic value, and the more frequent the injections, the more is the value to the patient and also to the society. And we have another option, that is the role of biosimilars, which are not exactly the generic drug, but as good as a generic in its efficacy. And systematic meta-analysis has shown that these biosimilars can be a useful alternative, especially when affordability is the issue. So the future, we should have drugs with longer activity like brolucizumab, with better protein binding affinity such as aflibercept, or drugs with longer half-life, or we need to resort to alternate delivery methods such as the port system. So to conclude, anti-VEGF therapy is not a curative therapy, but it has become the mainstay and is a pillar in AMD management. It can slow down the disease progression and can partially reverse the visual impairment. As of now, TND appears a most promising regimen. Biosimilars can be a useful alternative, and newer drugs with longer duration can help to extend the interval, and they are very useful in recalcitrant cases. Ongoing trials and the newer therapies are exciting options as the treatment of this impactful disease continues to evolve. Thank you.
Dr. Lekha, nice presentation. So in your clinic, actually, what percentage of patients do you treat with treat and extend?
Actually, to be honest, it's not a significant percentage. I think most of us are still, after the initial loading dose, what we find is most of the time we end up doing the PRN regimen, but of late I've tried to switch more patients into TND, especially the one-eyed patients. There I'm able to convince them more that every visit they need an injection. But other routine cases, for me, for personally, I'm in the evolving phase. I'm sort of in a transition from PRN to TND.
Thank you.
Thank you, Lekha.
Thank you, sir.
Dr. Das.